So I'm Lindsey Neece. I'm a clinical nurse specialist at Atrium Medical Center. I'm the advanced practice nurse in our heart failure clinic. So a clinical nurse specialist, I can do everything that a nurse practitioner does. Most people are more familiar with a nurse practitioner. But when I went to school, I also got extra education on how to be an educator and a lot of quality things. So I do a lot of quality things in our hospital. And my whole family is teachers. They all think I'm nuts from being a nurse. So it's nice. I do get the education piece, and I really enjoy coming out in the community and doing education. So it is Heart Month, so thank you all for coming out. We're going to talk about heart failure today. Some of the things we'll go over is what is heart failure, what are the causes of heart failure, how do we diagnose heart failure, how do we treat it, and just some tips for continuing to managing that on your own at home. And it is, like I said, Heart Month, and I also want to plug in that we are with Premier Health, but we have recently merged with a lot of our cardiac programs with Christ Hospital. So I'll talk about some of the benefits of that and how we work together later on in the presentation as well. So in the United States, nearly 6.7 million adults 20 years or older have heart failure. The lifetime risk of heart failure is 1 in 4 people. So look around the room, 25% of us will probably end up with heart failure, unfortunately. If you look at the map there, Ohio is there in that dark orange. So compared to the rest of the country, we have a very high incidence of heart failure. And unfortunately, the 5-year survival rate after a diagnosis of heart failure is about 50%. So I don't say these things to scare you, but I do say these things to take your health seriously and to really pay attention to your body and learn these things so that we can try to prevent that progression of the disease. So what is heart failure? It's a chronic progressive condition in which the heart muscle is unable to pump enough blood to meet the body's needs. So when we say failure, it doesn't mean that the heart has stopped. It means that the heart isn't pumping as well as it should to keep up with the rest of the body and the workload. So there's different types of heart failure, depending on the person and the type of heart failure that you have. Some people have trouble with relaxing of the heart, and some people have trouble squeezing the heart. So left-sided heart failure is primarily the type of heart failure that we talk about when you hear about heart failure, and that's further broken down into 2 different types of heart failure, systolic and diastolic heart failure. So systolic heart failure is where the heart muscles are not able to contract or pump out oxygenated blood. So that's the squeezing function of the heart. If we really get technical, you may hear people call it HFrEF or MF, I guess, is how we say that one. We don't use that one very often. But that's the squeezing function, and we'll talk a little bit more about that. And then diastolic heart failure, or HFpEF, is the muscles of the heart become stiff, and the muscles itself are harder than normal, and they don't relax as well. Okay, so a person can have left heart failure, right heart failure, or both, depending on what's going on. So a lot of times, as left-sided heart failure progresses, people can have issues with the right side as well. So those little diagrams talked about ejection fraction. So when we talk about how well the heart is squeezing, that's the ejection fraction, okay? It's how much blood at one time is pumping out. So a normal ejection fraction is 55 to 70%. Okay, so you're never pumping all the blood out of your heart at one time. So it's about 55 to 70% of that blood. So when we talk about that ejection fraction, that goes along with the systolic heart failure, or that squeezing function, okay? So when people have a lower than normal ejection fraction, they're not squeezing that blood out the way it should, and it can back up and cause the symptoms of heart failure that we're going to talk about, okay? So what can cause those things? The primary reason to have heart failure, or the cause of heart failure, is damage to the heart muscle from a clogged artery or a heart attack. So if you've known somebody who's had a heart attack or has bad coronary artery disease, it can make certain parts of the heart muscle very weak or damaged. Untreated high blood pressure, fast heart rates, heart valve problems, diabetes, viruses and illnesses. So we see a lot at this time of year where patients get a virus like the flu or COVID or something like that, and that virus can actually affect the heart. So we do see people who have heart failure related to a virus or an illness. Substance abuse, so drug use, alcohol use, pregnancy induced. So unfortunately, we do see patients who will be very healthy, they're young, they're pregnant, and because of the extra strain and stress on the body, they can actually develop heart failure during a pregnancy. So we do see that unfortunately as well. Stress-induced heart failure, we sometimes will call this broken heart syndrome. So this is literally when patients have a very traumatic event. We will see this if a patient loses a spouse, and obviously that's very heartbreaking, and it's very emotional and it's stressful, and just that stress on the body can actually cause heart failure. So luckily that is one of the types that often recover, but it is a very real thing. So when you hear people have broken heart syndrome, it's actually a thing. Familial or genetic, so some people can be born with different types of heart problems. Chemotherapy or cardiotoxic medication, so a little bit more commonly is there's some types of breast cancer treatment that the chemotherapy can actually cause issues with the heart muscle as well. So those medications we know are very, very strong. They're trying to do away with bad cells from the cancer, but in turn they can affect the heart as well. So what are the symptoms of heart failure? Unfortunately, people who have heart failure may feel and look like this guy here. They feel short of breath with activity and even at rest. So just getting up to go to the bathroom, they may feel more short of breath. They may feel especially short of breath at night when they're laying flat, because if they have fluid in their lungs, it causes them to be more short of breath and kind of, as that water spreads out in the lungs, it makes it more hard to breathe. Feeling tired even after a good night's sleep. So again, just getting up to go to the bathroom, you feel very, very tired, very worn out. They have swelling or edema, especially in your legs and feet, and some people have it in their abdomen as well. They gain weight, so that weight gain is usually fluid related. So this can happen over just a day or two, or it can be a slow weight gain over time as well. Coughing or wheezing, again, especially when you're laying down. Some people have sort of a frothy, foamy sputum that they may cough up. You may need to go to the bathroom more at night. So you always have to go to the bathroom during the day, but when you're going to the bathroom a lot at night, that's your kidneys and your heart kind of working overtime to get rid of some of that extra fluid. And feel bloated or feel fuller faster after a meal. So again, that's that fluid in the belly. So think about having a tight belt around your waist. If you have that fluid around your belly like that, you're going to feel bloated. You're going to feel like you get fuller faster after a meal and you're not eating as well. So if you present to the doctor feeling like you have any of those symptoms, they're going to ask you a lot of questions. Okay, when did the symptoms start? How long do they last? Does anything make it better or worse? You have to use a lot more pillows at night when you're sleeping, and that helps you breathe better because you're elevated a little bit more. Activity levels. Again, what were you doing 6 months ago? Were you, out walking the trails at Caesars Creek? And then now this week, you're so short of breath you can't make it to the bathroom. Again, sleep habits. So if you're requiring extra pillows, pain, lightheaded, dizziness, other comorbidities and family history. So does this run in your family? Do you have high blood pressure? Do you have diabetes? All of these things really come into play with heart disease. Medications and substance abuse. So back to that, have you been treated for cancer and you had some of these toxic medications? Or is there a drug and alcohol history? Psychosocial issues. So this is a very real thing, especially as the cost of everything is going up. I know right this month, everybody is having to get their deductibles caught up with for the year with their insurance. So these psychosocial issues, you're not able to afford your medications. So, you may have high blood pressure, you may be on your blood pressure medication, but if you can't afford it, that's that extra work on your heart because your blood pressure's high and your heart's having to work overtime. So all of these things really go into play. So the next thing they're probably going to do is run some blood work. We're going to look at a CBC or a complete blood count. So this looks, is there any infection? Unfortunately, signs and symptoms of heart failure they sound a lot like a lot of other things, like pneumonia or COPD or things like that. So sometimes we have to do a little bit of detective work to really see what's going on here. So we're looking at the complete blood count. That can tell us, is the white count elevated? Is there any type of infection? Are you anemic? So are the blood counts low? So if we're looking for any type of anemia, those iron studies are going to come into play. When you have low blood counts or low iron, that can be a cause of being really tired. Thyroid studies. So we talked a little bit about rhythms can cause heart failure, a bad heart rhythm. So people who are prone to atrial fibrillation and different types of heart rhythms can have thyroid issues. So again, we're going to check those things. Renal panels. So this is looking at your kidneys. Your kidneys and your heart go hand in hand. If one of them's not happy, the other one is probably soon to not be happy as well. So it is a constant balance with the fluid status, with medications, with blood pressure, and all of those things. Same with liver function test. So that's another blood work. If you're holding that extra fluid in your belly, it can affect the liver as well. Lipid profile, so that's just a good thing to know what your cholesterol is and the risk of heart disease. And then a brain natriuretic peptide, so that's a BNP. That's a blood test that we do very commonly in heart failure. It can let us know if there's extra fluid on board and how advanced the heart failure is. There are other things that can cause an elevation in that blood test, but we do look to that a lot to see what's really going on. The next thing are some diagnostic tests. So I can guarantee you 100% if you show up in the hospital, you say you're short of breath, the first thing they're gonna do probably within like 30 minutes is get a chest x-ray. So they're gonna look to see, is there fluid in the heart and is the heart enlarged? So you can see the difference in that x-ray there at the top, that the normal size heart on the left and then a very enlarged heart that's been working overtime there on the right. An EKG, so you see there in the middle, that's just an EKG strip. That's actually atrial fibrillation. So again, those heart rhythm issues can cause the heart to kind of be out of sync and cause issues as well. An echocardiogram, this is the test that we're gonna get probably the most information out of. So down here is an echocardiogram. I am terrible at reading these, so don't ask me on these. But if you look at them here, you can see what the heart looks like. It is flipped upside down. But this is where the physicians who are reading these are really getting a good idea of what's going on in the heart. So they're going to look at the valves. Okay, is there any valve issues? Are they opening and closing the way they should be? What is the thickness of the muscle? So if the muscle is really thick, that might tell us that the heart is having to work extra hard. Okay, they're also looking at that squeezing function. So this is where we're going to get that ejection fraction to tell us how well the heart is squeezing and working, as well as that relaxation piece, that diastolic piece. Okay, exercise testing. So patients may or may not have chest pain with heart failure, but as we mentioned before, oftentimes if patients have coronary artery disease or have had a heart attack, it can lead to heart failure. So oftentimes we'll get a stress test to look and see if there's any damaged heart muscle when the heart is under stress or exercise. So it's a little bit less of an invasive test if we're just gathering some information. If it's highly suspected based on EKGs and chest pain and blood test, then we may go right to a heart catheterization. And that's where they stick a little tube up through the groin and it goes into the heart and they shoot x-ray dye and it looks to see if there's any blockages. Okay, so if there are any blockages, they can fix them right there. So oftentimes they'll put a stent in there that helps to open up those blocked arteries to get better blood flow to the rest of the heart. Sometimes they may say it's there, it's not anything that we can fix at this point. We're gonna make sure we're on good medical therapy. So cholesterol medications, keeping the blood pressure well controlled, exercise, things like that. If they find a lot of blockages that need fixed, then they may have to consider open heart surgery where they go in and they take usually vessels from the leg and they transplant them up into the heart to help give better blood flow to the rest of the heart. So, okay, has anybody known anybody to have open heart surgery? Yep. So it is a pretty big deal. It's a pretty invasive surgery, but it is, for the most part, pretty common at this point, and there are very good outcomes when patients have to have these surgeries done. And the other thing is a right heart cath. So usually they go in through the neck on this one, and it looks at all of the different pressures in the heart. So it looks how well the heart is getting that blood pumping, the output of the heart, and it's also looking at all of those different pressures in the heart. So if certain pressures are high, that can indicate that there is extra fluid on board. It can also work indicate that different parts of the heart are working harder than they need to be. So what are our goals of treatment? Our whole goal is to slow the progression of the disease. So unfortunately, heart failure is a progressive disease. It can get better, and I tell my patients all the time, you can have heart failure but not be in heart failure, so that's sometimes kind of confusing to think about. But most people after a diagnosis of heart failure will always have heart failure. It's just a difference of, are you in an active exacerbation, okay? So we want to slow that progression, we want to decrease the symptoms, and we want to prevent exacerbations that lead to hospitalization. So unfortunately, when patients start going down that road of getting in the hospital, it's very highly likely that they're going to continue to end up back in the hospital. So the more we can slow this progression, the better off the patients are going to be in the long run. So one of the things that we look to is guideline-directed medical therapy. So the American Heart Association, the American College of Cardiology, they gave us very good recommendations of how we should treat our patients. So there are 4 pillars of medication. A lot of the studies revolve around the patients who have the squeezing issues, that systolic heart failure, or HFrEF. But a lot of these same medications also help with our HFpEF patients or the diastolic patients, okay? So I'm gonna go over all of these. Some of the recommendations are better or not as strong for HFpEF versus HFrEF, but it is all of the same medications for the most part. And that's probably a little hard to read, but I'm just gonna go over each drug class because it is very important that if you're on these medications, you know why they're important and why you're taking them. So the first class is an ARNI, so an angiotensin receptor neprilysin inhibitor. It's a mouthful. It's an ARNI is what we call it, okay? And that's typically Entresto. Unfortunately, it is a very pricey medication. It is preferred over some of our older, less expensive medications like lisinopril or losartan, but we use what we can based on what our insurance is gonna pay for and things like that. So one of those medications is recommended, whether it's an ACE, like your lisinopril, an ARB, like your losartan, or an ARNI, like Entresto. But these medications reduce mortality and they lower blood pressure. What we do need to watch with these medications is to watch blood pressure, watch kidney function, and as I mentioned, they can be pretty pricey. Beta blocker, most people are pretty familiar with these. Metoprolol succinate, carvedilol, or bisoprolol are the most common medications that we use in this drug class. Again, it reduces mortality, lowers blood pressure, and heart rate. So we do need to monitor for heart rate and blood pressure, and some of these medications can cause fatigue or tiredness. So if you're having any of these symptoms that become intolerable, it's really important that you let your doctor know or your provider know so that they can get you on something that's going to work. Okay. Aldosterone receptor antagonists, or an MRA. This is aldactone or eplerenone. Again, these reduce mortality, lowers blood pressure. It does have a little bit of a diuretic effect or a water pill effect to get some of that fluid off. So we need to monitor blood pressure, kidney function, especially potassium, because these medications do make you hold on to potassium, which is not a bad thing, but we just need to monitor it. And it can cause gynecomastia, which is a big word, but it can cause breast tenderness in both males and females. So again, if there's things that you're not tolerating, let your provider know, because sometimes there's some extra options that we look at. SGLT2 medications, anybody heard of Farxiga and Jardiance? You've probably seen the commercials. I think there's a Jardiance commercial and they're like dancing around the farmer's market in fancy dresses, you know that one? You're seeing that commercial as a diabetes medication, okay? When they did studies on these medications, they put all the diabetics on Farxiga or Jardiance or whatever it was, and lo and behold, all the patients with heart failure did much better. So now we use it as a heart failure medication as well. So you don't have to have both to be on this medication. If you do, you're gonna get benefit for both your heart failure and your diabetes. But we do use this as a primary medication just for heart failure as well. So it reduces mortality, which you know, reducing death is always a good thing, right, in heart failure. It prevents remodeling, so that's preventing that shape changing of the heart that makes it not function as well. It works as a mild diuretic, so it's getting some of that fluid off. It can be kidney protective. So again, we have to keep the heart and the kidneys happy. So this can actually protect the kidneys. And it lowers blood sugar. So what's not to love, right? It's very helpful for our patients, except for the cost. So sometimes we do have to really talk to our insurance companies about this. Another few things that we need to watch with these medications is it can cause UTIs because you're urinating extra sugar out. So people can be prone to UTIs on these medications. So we just make sure people are aware. Euglycemic DKA. So that's a big word for a diabetic event that can cause a hospitalization, so a ketoacidosis, but you have normal blood sugars. Okay, so it's kind of a confusing concept, but the long story short of that is if you are a true type 1 diabetic where you don't make any insulin on your own, you should not be on this medication, okay? So keep that in mind. If you are a true type 1 diabetic, we don't like patients to be on those. We do need to watch kidney function, and I like to make sure people are aware you should hold these medications for 72 hours prior to any procedure, any medical type procedure. I have seen so many procedures get canceled because they didn't hold the medications ahead of time, and they show up and the anesthesiologist says, nope, we're gonna reschedule you. So make sure you're talking to your people who are scheduling your procedures. Make sure you know what medications you need to hold ahead of time because this is one they will cancel procedures for. Okay. So those are the 4 pillars of medications that we really try to get our patients on. And not only do we want you on the medications, we're going to try to increase the dose to the best tolerated level that you can take. So as long as your kidneys are doing okay, your heart rate and your blood pressure, we're going to continue to adjust those medications the best we can to give your heart the best chance at getting some recovery. Okay. The other medications that we use, I say this is kind of tools in our toolbox, okay? So you may or may not be on some of these other ones. Diuretics, so most heart failure patients are gonna be on a diuretic. The most common one is furosemide or Lasix. Some people are on torsemide or Bumex. Some people are on what's called metolazone, which is considered a super water pill that you may or may not take every day, just kind of in an emergency type situation. But it helps get that extra fluid off. So if that fluid's building up in your lungs, you're having extra swelling, it's going to help maintain that. And again, we need to watch blood pressure and kidney function. Nitrates and hydralazines. So some patients, due to their kidney function, are not able to tolerate the ARNIs or the ACEs and the ARBs, the very top class up there. So sometimes we substitute medications that will still allow a little bit of benefit to patients if they're not able to tolerate that. So we will do that as well. And then avabradine is another medication. We like the heart rate to be around 70. So if the heart rate is always really fast, the heart is having to work extra hard, right? But if your blood pressure is on the low side, which is not a bad thing, we can't increase that beta blocker to lower the heart rate further. So sometimes we have to use a medication called avabradine or Corlinor. It will lower the heart rate, but not the blood pressure. So we kind of have to balance those things out, okay? Any questions on medications? That's a lot on there, I know. Okay. All right. So, but the long and the short of it, take your medications as instructed, okay? Don't do a guessing game. If you have questions, call your provider, but take it with what the label says unless somebody told you otherwise. Don't stop or start a medication without talking to your healthcare provider. So medications like NSAIDs or anti-inflammatory medications like Advil, Aleve, ibuprofen, those can actually cause salt and fluid retention and can affect the kidneys. So if you have heart failure, typically we recommend Tylenol versus the NSAIDs like ibuprofen and like that. Avoid over-the-counter medications such as pseudoephedrine. It's found in a lot of cold medications. So as long as you don't use a cold medication that has a decongestant in it, so you may see like Mucinex D, don't get the D, okay? It's that decongestant that can cause issues for cardiac patients. It sounds obvious, but don't allow yourself to run out of medications. So if you're going on vacation, plan ahead of time, make sure you have all of your medications to go with you. If you're having trouble getting your medications, call the doctor's office. And when you come to your appointments, bring a current list of your medications and the bottles. It is very helpful for us to see exactly how patients are taking it. Sometimes you're on medications and you're back on or off of them, and you know the prescription can change a lot, but you've got all these bottles in your cabinet and you don't want to waste them. So we want to know exactly how you're taking your medications when you come into the office. And the biggest thing is be honest, okay? If you don't like taking a certain medication because you don't like the way it feels, it's not doing you any good. Okay, so let's work together and find something that is going to help your heart and you're going to tolerate whatever side effects those might be. Take your medications at the same time you do other activities, so like brushing your teeth or watching the news. I had a patient just the other day. He said he always forgets to take his evening medications. I said, put it with your toothbrush. If you know you're going to brush your teeth at night, put it with something that you know you're always going to do at the same time of night. So find a way that's going to work for you. If you need to set an alarm clock, there's lots of apps out there now. If you have smartphones, they will remind you to take your medication. If you have a pill box like the one down here in the picture, these are really helpful to help you remember, did I take it, did I not? You've got it all lined up for the week, and you don't have to worry about it so much every day. You just take what's in the little box for that day and you move on, okay? All right, so that's kind of the pharmaceutical thing. So those are the things that I can say, make sure you take your medicine. But these are the things that you have a choice of how you're going to move forward with, okay? So activity. The American Heart Association recommends 150 minutes per week of moderate intensity aerobic activity, or 75 minutes per week of vigorous aerobic activity, or a combination of both. So what does that look like? That can just be going on a nice walk, not a slow walk, but a brisk walk where you're getting your heart rate up a little bit. Water aerobics, dancing, gardening, tennis, biking slower than 10 miles an hour. So this is just more of a consistent pace of something that's getting you up and moving. And then consider adding muscle strengthening activity such as resistance or weights at least twice a week. So just small hand weights or those exercise bands that you put on your legs and you stretch them out, those are all really helpful things too, okay? Spend less time sitting. So, you know, if that means getting up and going to the refrigerator, hey, at least you didn't have somebody else do it for you, right? Get up and do it for yourself, okay? This is your health and we want to make sure that you guys are putting the effort into it. Walk to the mailbox. You know, the next day walk a little farther than the mailbox and then come up. So gradually increase the amount and intensity gradually over time. I don't expect my heart failure patients to be training for the flying pig, okay? So we meet people where they are and we really just want you to continue to increase your activity. A lot of people have smartwatches or smartphones now and they have step counters on them. So just pay attention to your steps on your phones or your watches as well, and just try to increase your steps per day. So every little bit really helps a lot. So I like to give this calendar out at my work. It's for Heart Month, so there's only 28 days on it. But what it does is it kind of gets you something to think about. And not all of these are exercises. Some of them, let's see, take the Heart Month pledge to move more. That's just saying, yeah, I'm gonna do it, okay? This says make sure you get 8 hours of sleep at night, okay? But today says add a stretch. So everybody stand up. We're gonna stretch. If you're able to. Come on, Pastor Terry, stand up. So just put your arms up and go side to side. All right, twist around a little bit, touch your toes. All right, that's it. I won't make you guys do more. Gotta keep you awake though. Okay. So a little really goes a long way, okay? Like I said, the less you're sitting, the more you're doing activity. I know it's miserable outside right now to think about going outside and walking to the mailbox, but do little things around the house as well, as much as you can. Some patients may qualify for cardiac rehab, so this is a little bit more of a controlled setting for exercise. So patients who have that low squeezing function of their heart, that low EF, If you've had a heart attack, open heart surgery, or a stent, your insurance may pay for cardiac rehab. So we do have a cardiac rehab facility at Atrium, and I believe there's one at Miami Valley South, and other hospital institutions I know have them as well. I'm just not as familiar with like Kettering and things like that. But they do have them around the area. You go, you're with an exercise physiologist or nurses, and they have you on a heart monitor and they meet you where you're at. So they're gonna help you set exercise goals, and your whole goal is to get that heart stronger over time. Not only that, they do talk about diet, reducing stress, medical therapy, like we talked about, and stopping smoking. So it's really kind of an all-inclusive way to get good information about your heart and keep moving.
Does caffeine work into this at all?
No, we want your heart rate to go up by exercise, so. But you know, and my next piece is to talk about diet, and really everything is in moderation. So, you know, I have my cup of coffee or cup of tea every day. I don't have 5. You would see me flying around this whole town. I would be running the flying pig at that point. But, you know, a little bit of caffeine. We certainly don't recommend smoking or drugs in any capacity. You know, even a glass of wine or, you know, one serving of alcohol is okay here and there. It's everything in moderation, okay? The thing that we do like to talk about is the DASH eating plan. So that's a dietary approach to stop hypertension, which is high blood pressure, and it's recommended for improving overall heart failure. And what this does, a lot of it is to focus on the sodium or the salt content. So it didn't really require any special foods. It provides daily and weekly nutritional goals, and it recommends really kind of getting back to the basics. So eating vegetables and fruits and whole grains, right? We all know we should eat more vegetables and more fruits, right? Include fat-free or low-fat dairy products, fish, poultry, beans, nuts, vegetable oils. So think of your food pyramid that we all learned in elementary school. I think it's a little bit different now, but we know the things at the top, limiting foods that are high in saturated fats, fatty meats, full-fat dairy products, oils. You want to avoid coconut, palm kernel, those types of things, and certainly limit sugar-sweetened beverages and sweets. And a lot of studies now show that the artificial sugars are just as bad as the, you know, lots of sugary foods. So think about those things. Everything in moderation is really, you know, have the sweets on occasion, don't have it every day or big portions, something like that. So in general, we recommend limiting salt intake to 2,000 milligrams a day. Okay. Avoid processed foods. So typically if it comes in a can or a box, it's going to have a lot of extra salt in it. Use seasonings such as Mrs. Dash. And if you think about how much is 2,000 milligrams of sodium, which is what we recommend for the whole day, is about 1 teaspoon. Okay. So without seeing the front of it, does anybody know what this package is? Ramen noodles, right? Okay. So how much sodium, I don't know if you can see it, how much sodium do you think is in the ramen noodles?
830 milligrams.
830 milligrams. When you eat ramen noodles, how much of the package do you eat?
2 packages.
But let's be real, we eat the whole package, right? So this is saying that a serving, there's 2 servings per container. Okay, so 830 milligrams and you eat the whole package, that's 1,660 milligrams of sodium that you've had in one meal. And you probably had something else with the noodles anyways, right? So think about that when you are eating. I'll be the first to admit my kids love ramen noodles. I shouldn't even ever say that out loud. But I have that sodium packet in it, okay? So find little ways to cut out that sodium, you know, add some vegetables to it, you know, stretch it out a little bit more so you're not getting all of that salt content in there, okay? It's very hard. We live in a very processed world. So if you're eating out a lot, if you're eating convenience food, it's by default going to have a lot of salt in it. So again, try to get back to the basics. Frozen vegetables typically aren't so bad if it's just the vegetable itself, but if they're in a lot of the sauces and gravies and cheeses, all of that's going to add a lot of extra sodium to things as well. Fluid intake. So a lot of people have trouble getting the amount of fluid that they need for the day, but a lot of people also drink way more than they should. So typically for heart failure, we recommend about 2 liters of fluid a day, okay? If you drink less than that and you have heart failure, don't push yourself to 2 liters of fluid a day, okay? But if you typically drink more than this and you have issues with swelling and things like that, it may be time to start cutting back on that fluid intake. So 2 liters, think of a 2-liter bottle of pop. That's what you can have for the entire day. That does include juice, water, ice cream, Jell-O, soup, ice, some fruit. If you eat large amounts of watermelon, it's going to have a lot of fluid in it as well. Coffee, tea, all of those things. So if you feel thirsty, because some medications do cause you to be thirsty, you can do things like ice chips. So when ice melts down, if you have a whole cup of ice and it melts down, it's about half a cup of water. So it's about half of the volume, if you will. So use ice chips so it slows down your guzzling of fluid and you can kind of keep your mouth moist that way. Freeze juice in ice cube trays, use hard candies, sugar-free if you are diabetic, chewing gums or lemons just to kind of keep that mouth moist. And another thing to think about is if you are really thirsty all the time, how are your blood sugars going? So if you have really high blood sugars, that can make you urinate a lot more and make you feel extra thirsty as well. So keep those things in mind. So signs of true dehydration, we do want to watch this. We're constantly watching, are we swollen? Are we drinking and eating too much? But we want to make sure we're eating and drinking enough and not losing too much fluid too fast. So if you have decreased urine output, a headache, dizziness or lightheadedness, especially when you stand up too fast, your blood pressure is on the lower side. If you're getting blood work and you're having rising creatinine, which is a part of a blood test that we look at, or if your weight continues to decrease over a period of a few days. So I've heard this flu season is terrible right now, and if you've had the flu, you're not eating and drinking very well, and then a couple days later you notice that you've lost a lot of weight and you're having some of these symptoms, that's probably dehydration. So sometimes we do need to adjust our water pills based on the bigger picture. So typically what we do after diagnosis of heart failure is we get patients on the right medications, we work on diet, we work on exercise, and then we're gonna do another ultrasound. And this is specific again to our HFrEF patients or the low EF, okay? So after 90 days, we're gonna check another ultrasound and see how is that squeezing function, okay? If the EF is still less than 35%, then your cardiologist may talk to you about a defibrillator. Okay, when patients have a very low EF, what that can put them at a higher risk for is a bad heart rhythm because the heart's kind of stretched out, it's floppy, and the electricity that goes through the heart to help it beat isn't kind of firing the way it should. So it can cause kind of misfires and cause bad heart rhythms. So at that point, your cardiologist may recommend that you have a cardioverter or defibrillator or an ICD. And that's that picture there at the top. If you're familiar with a pacemaker, it's that little device that goes underneath the chest tissue, and there's a wire that goes into the heart that helps it. If you go into those bad heart rhythms, it's going to shock you out of it. Okay, there are different types of devices. There are pacemakers. That's not necessarily specific to heart failure. That's if you have a very low heart rate. So if your heart rate goes below 50, that's probably too low. So they may want to make sure that your heart is beating appropriately. And cardiac resynchronization therapy. So sometimes the two ventricles on the bottom of the heart, which is the two chambers, they're not working together. So a CRT device can help those things resynchronize and beat better together. So that's kind of the progression of heart failure. We get to that 90 days and we see where we're at. And then from there, we kind of look and see are there any other things that we should be doing. So if there's more medication titration that we need to do, any further workup or testing, if you're having a really hard time staying out of the hospital and having difficulty with fluid status and adjusting water pills and things like that, we do offer a device called a CardioMEMS here at Premier. My partner, Dr. Katak, he's a a Springboro physician actually. He implants what's called a cardiomem. So it's this little device up here. The sides of it are just little wire, and it helps embed itself into the pulmonary artery. So it's implanted in the cath lab. They go up through the groin, they implant it in that pulmonary artery, and then what it does is it monitors pressures in the heart. So when you go home, you get a pillow that you lay on every day. These readings come to me in the heart failure clinic, and if the pressures in your heart are increasing, oftentimes it can mean that you have extra fluid on board. So I get on the phone, I say, what's going on? Your pressures are going up, how are you feeling? And oftentimes it's, oh yeah, my weight's up. Or, oh yeah, I'm more swollen and I'm not breathing as well. So we can adjust the water pills right then and there over the phone, and I watch those pressures come down the next day. So it doesn't actually fix things. It's not something you put in and it makes your heart work better. What it does is it helps us better monitor you so that we can prevent those hospitalizations. Okay. Another thing that we do, and I do have extra information out there if you guys are interested in learning more about that. Another thing that we may need to consider in the future for patients who their heart just isn't getting better is advanced heart failure treatments. So a left ventricular assist device, or an LVAD, this is the picture on the very bottom here. So what that is a device that attaches to the heart and it helps circulate the blood. So if the heart isn't squeezing like it should, it's not pumping that blood. So this device actually helps circulate blood through the rest of the body and gives that cardiac output is what it's doing. Okay, so the Achilles heel of this is that it is not completely internal. I'm gonna step up here. So this is the device itself that's inside the heart, and this is called the drive line. So there is no internal battery the way it is on these devices. So this drive line comes down and it actually comes out the abdomen. It's like a cord, and then it has to hook to the batteries that you wear in a holster outside, and the batteries have to stay charged. So they are working on devices that are fully chargeable on the internally, because what can happen is that drive line, as I mentioned, it's the Achilles heel of things. The biggest thing is infection with that coming out of the body, and if there is an infection on that drive line, it's a direct highway right to the heart. So those can be for people who maybe are not eligible for a heart transplant for whatever reason. Maybe they're too old, or maybe they're not interested in a heart transplant, or whatever the reason is, that can be considered an option. Or maybe they really need a heart transplant, but they're not able to get it as soon as we would like them to. So we call that bridge to transplant. They will get the device. They will utilize it as long as they have to wait until they get that heart. So the heart transplant is kind of the ultimate heart failure treatment if patients need to go down that road. So,
do you unplug it when you want to go swimming?
I'm sorry?
Do you unplug it when
There is no bathing. You can shower, but you cannot be submerged in water. So that, again, that's kind of that Achilles heel. Some patients opt not to do that because of, lifestyle stuff. They don't want to have to give up those things. They want to talk about quality of life at that point. So yes, there's definitely pros and cons to it. I would say in our lifetimes, they will be having better options that will be more internal, and that patients will be able to do more of those things. So with our Christ Hospital joint venture, so our whole goal is to be able to have patients be worked up for these procedures if they need them, rather than having to go all the way down to Cincinnati, meet with a doctor, get referred for tests, have lots of driving to do. We now have advanced heart failure doctors here within Premier at our Atrium and Miami Valley locations. We can start doing some of this workup, get patients listed on a transplant list before they even need to go down there. Okay, so to date, I believe we have had 8 LVAD procedures done and 2 heart transplants from people right here in our area with this joint venture that we've had. So we are able to do those referrals, get them worked up, and then they go down to Cincinnati for the procedure. So it's really exciting. Prior to that, people would have to do all of their care at either Cincinnati or Columbus, and that's a lot when we live, all the way up here, and you're having lots and lots and lots of doctor's appointments and things like that. So we're really excited about that. Christ Hospital has been very supportive of our program. So any questions on that? Yeah.
You said you could be too old for a heart transplant. How old is too old?
I believe it's 75.
Okay.
Yep, did you have a question?
What if you've had a pacemaker for 5 years and you've never been shocked?
So a pacemaker doesn't shock. So depending on what kind you have, there are some that do both things. So if you have a true pacemaker, all it's doing is if your heart rate falls below a certain, whatever your thresholds are, so most of the time it's like 50 or 60, if your heart rate goes below that, the pacemaker will kick in. If you have a defibrillator, that's kind of like insurance. You hope you're never going to need it, but by golly, if you do, you're very happy that you have it. So that's when you have that bad heart rhythm, and you will feel a shock, and it's like, oops, sorry. It feels like it feels like a kick to the chest. Okay, but most people, essentially, if you require a shock, if you don't get that shock, you're essentially dead, to be very frank with you. But that's what it is that defibrillator shocks the heart, just like a code blue like you see on TV when they shock people. That's what a defibrillator does. It shocks the heart back into the correct rhythm that can provide that blood flow and that efficient heart pumping.
So if it doesn't do anything for a 5-year period,
Then you're lucky.
on your way, you're out?
No, that means you're very lucky that you've not needed it. Yes, no, it means that you haven't needed it. And you're a cardiologist, so usually, depending on how they do it, they're all different, but most of them will send a reading every month, and the cardiologist will download it. So they can look, were there any goofy rhythms at any point in time? Some of them can actually look at the fluid status, kind of like the cardiomems that I mentioned. Some of them do have some capability of looking at that, those fluid pressures around the heart to see if there's extra fluid as well. So again, there's a lot of different devices, and they all work a little bit differently, but your cardiologist can get a lot of information from those, and essentially no news is good news. So if nobody has called you in a panic, that's a good thing.
So we have a monitor, you know, by our bed. So I assume that every month then they get a reading on this?
Yep, and some of them, they may download every night, but usually, like for the cardiomems, I do a print off every month, and that actually goes into the chart. So they kind of work on a no news is good news type of thing. So yeah.
I figured they'd never bothered to look.
Usually they're doing a lot in the background, but when you follow up with your cardiologist, ask them, just say, has there been any events, or, you know, or am I really boring? And that's a good thing. So, okay. Did you have a question too?
That LVAD, is there an age where that's even too old for?
So I don't know specifically if there's age with that, but a lot of times it's the social support that pulls people out of the eligibility for this one. So let's say you have no family that lives in town, you can't drive, you know, you just don't have a lot of social support. They would probably not put an LVAD in somebody like that who doesn't have that social support. So there's a lot of things that go into those decision making. Same thing for a transplant. You know, they have to know that you're going to take care of these things, that you're going to take medications appropriately, that you're going to do all of the things that are required to maintain it. So, okay.
Is that device kind of universally known at other hospitals, such as Kettering?
Yes.
Okay.
Yes. So I do know that up at Miami Valley, they are working on getting an LVAD program established, not for the implants, but for patients to be able to follow up after they've had it down at Christ. So there is certain equipment that does the readings and things like that. So they are working on doing that. I think there's one other device that, depending on surgeon preference and the patient themselves, that they may choose from. But this particular one is the one that's most widely used. So, okay. So you mentioned, you know, who's eligible for these things, who's not, what happens after that? So nobody likes to have these discussions of goals of care, but I am a huge proponent for having these discussions with your family. If something happens to you in the hospital and you're not able to make your own decisions, who is your decision maker, okay? If you don't like your spouse, and I don't say that to be funny, but if you don't want them making decisions for you, it's going to default to them or your children, okay? So make sure you have in writing who you want to make that decision for you, and have that discussion with your family. If you would never in a million years want to be intubated or shocked or any of those things, tell your family that, because if you come into the hospital in an emergency, we are going to do all the things to keep you alive unless we know otherwise, okay? So consider advance directives. So that is that legal document that lets you say what it is you do and don't want and who you would like to make those decisions for you. And the other thing I like to talk about is palliative care and hospice care. Is anybody familiar with palliative care? A little bit? Okay. So palliative care, I like to say, is not hospice care. Okay, the biggest difference with palliative care is that you can still go for treatment. Okay, oftentimes cancer patients do palliative care, and it's really kind of evolved into the cardiac world as well. So what it does is it helps with symptom management. So if you have pain or shortness of breath or chest pain or whatever the chronic issue is, they're going to help you manage those symptoms, but still allow to have some of that treatment. Okay, they are usually another provider. Oftentimes it's an advanced practice provider like me, but they work with a physician. Sometimes they come to your home. Sometimes you go outpatient to see them in a doctor's office. But what they're trying to do is help you manage your symptoms. Now, hospice kind of goes a step further, whereas that's where you're not opting for actual treatment anymore. So if you're not eligible for a heart transplant or an LVAD and the heart failure continues to worsen, then we may talk about hospice care and comfort care, okay? So oftentimes in hospice care, you're gonna continue your medications, but they may not escalate things. And if you do start having worsening symptoms at home, it is always an evolving discussion with your hospice provider and still your other doctors that are on your team to say, if I get worse, am I still going to come to the hospital, or do I want to be able to live out my days doing the things that I still enjoy as much as I can in my home, or where sometimes it's in a facility and things like that. So, like I said, it's not a topic that people like to talk about, but I think it is so very, very, very important. I always use the example of my father-in-law. We lost him about 10 years ago, and my husband, he didn't know what to do. He said, how am I supposed to know what to do with all of this stuff? And, what would he want? And he found a letter that was addressed to him in his house, and it said, Bill, if you don't know what to do, here's what I want. So it would have been nice if he told us that. But have those conversations with your family so that they know exactly what to do. And truly, as children with aging adults and like that, it really is a gift that we don't have to make those decisions, that we know that you have made that decision, and we're giving you what you want in those last times as well. So, okay. So the last thing I just want to touch on is if you have heart failure or any type of chronic disease, is to make sure that you are in good contact with your healthcare team. So when you're doing good, you're doing good. Keep up the good work. We like our patients to weigh themselves every day. Get up, go to the bathroom, get on the scale. If you gain 2 to 3 pounds overnight or 5 in a week, that should be a call to your doctor. That's when you're getting in this orange and yellow zone. If you're more short of breath, if you can't lay flat to breathe and you feel smothery, call your doctor. Oftentimes we can adjust those medications, keep you out of the hospital, because that red zone down at the very bottom is the hospital, and we really want to keep people out of the hospital, okay? So other things that you can do, whether you have an actual cardiac diagnosis or not, we want people to know your numbers. So blood pressure, less than 120 over 80. Okay, I think you can still go into the pharmacy and stick your arm in one of those tubes and check your blood pressure. So you don't even have to go to a doctor, but you can go on March 22nd at Dorothy Lane, right? And get those checked. And are they doing blood pressure screens and A1Cs and stuff too?
They are doing blood pressure, total cholesterol, HDL, blood sugar does have to be fasting, and hemoglobin A1C. So no
Perfect.
tris or LDL.
Okay, so you can get the majority of these things tested without even having to go to the doctor, but we really want you to know these numbers so that you can take action on those things and not end up, having heart failure or heart disease and things like that. Fasting blood sugar less than 100 or an A1C less than 5.7, BMI less than 25. So, people who are more round in the middle, kind of that apple shape, shape, those patients or people are going to be more prone to cardiac disease and diabetes and metabolic diseases and things like that. So, really pay attention to your diet and your activities and your exercises, and know all your numbers so that, you can prevent these things in the long run. Another thing that I just like to mention, because I don't think it gets mentioned enough, is sleep studies. So if you snore, that's putting a lot of extra strain on your heart. It's increasing your risk for heart disease. It can raise your blood pressure. And again, it's that strain on your heart. So it can have a lot of issues, kind of that downstream effect. So talk to your primary care doctor if you snore, if your partner notices that you're not breathing at night or you wake up gasping for air, it might be time to consider a sleep study if you have not had one of those done. So they do get a lot of really good information on that. A lot of people will say, I don't want to have to go somewhere and stay overnight. Oftentimes they can do them at home now. My mom just had one done, and she, puts a little device on at home, and they do all the readings there, and she take it back to the doctor the next day, and they give her the results. So it's a lot more less invasive than it used to be. And even the mask, people say, I would never want to wear one of those masks. If you do, they're going to find one that fits for you. So they do have the ones that just go over the nose. They have the full mouth ones now. But you don't know the damage that you're doing to your body until you get the test and really know what's going on. So, okay. All right. Well, thank you guys all for joining us today. Thank you.